Let's ultrasound. On today's edition of GYN Ultrasound, it's all about uteruses. So first, let's start with the protocol. And this is the protocol for a transabdominal ultrasound. You want to start with a sagittal uterus with and without length and height measurements, and then move into the sag endometrium. And for this, we're going to do a grayscale image with and without an AP measurement, and then a color Doppler image of the sagittal endometrium, looking for any flow within that endometrium. And it's crucial for the sagittal uterus and sagittal endometrium images that the endometrial stripe is elongated from the fundus to the cervix. This is how you know that your images are on axis. And then it's time to move on to the transverse uterus. And for this transverse uterus, it's really important that you're actually in the body or the fundus of the uterus and not down by the cervix. So make sure you sweep up high enough in the transverse plane and you're covering that uterus at its maximum width. And you want to take this transverse uterus image with and without a width measurement, which is going to be a horizontal measurement on the screen. Next, do a cine clip sweep from anterior to posterior of that transverse uterus. And then it's time to move on to the sagittal cul-de-sac. And this is going to be looking anteriorly and posteriorly to the uterus to look for any free fluid. Time for the ovaries. Starting with the transverse right ovary, you want to take a grayscale image of the transverse right ovary with and without AP and width measurements, and then follow that up with color and spectral Doppler images of that transverse right ovary. And then jump right into the sagittal right ovary with and without a length measurement. And then one of the most important images that you take is a transverse right adnexal picture. Adnexa is just a fancy word that means next to. So this is the space that's next to the uterus that encompasses the region that has the ovary and fallopian tube and broad ligament. And you're just documenting that there's no free fluid or masses within this space. Then you want to repeat all of that for the left adnexa and the left ovary. Now let's dive into the protocol for a transvaginal ultrasound. For your long or sagittal uterus picture, you want to start with the mid picture, and this is where you can see the endometrial stripe, and you want to elongate that endometrial stripe all the way from the fundus to the cervix. And you want to take this long uterus picture with and without length and height measurements. And then also sweep right lateral and sweep left lateral and document those sections of the sagittal or long uterus. Then it's time to move on to a sagittal or long endometrium. And you want to do a grayscale image with and without an AP measurement, and then a color Doppler image to evaluate for any flow within the endometrium. Then on to a sagittal image of the cervix, and then a coronal image of the cervix. And very important to not measure any simple Nabothian cysts, as these are considered a very normal finding in the cervix. Next, it's time for the coronal uterus, and you want to make sure that you're measuring this uterus at its maximum width. Make sure that you're not within the cervix or the isthmus of the uterus, but by the fundal end of the uterus. And you should see the endometrial stripe horizontally extended throughout the uterus. And you want to take a grayscale coronal uterus image with and without a width measurement, and then perform a coronal uterus cine clip sweep from inferior to superior. Next, it's time to move on to the cul-de-sac. Take a sagittal cul-de-sac image demonstrating that there's no free fluid in the anterior or posterior cul-de-sacs, and then move on to the right adnexa, documenting that there's no masses or free fluid within that right adnexal space next to the uterus. Then it's time for the ovaries. Start with a coronal right ovary and do a grayscale image with and without AP and width measurements, and then color Doppler and spectral Doppler images of that coronal right ovary. and then move on to the long or sagittal right ovary. And you want to document this with and without a length measurement. And then repeat this for the left adnexa and also the left ovary. Let's do a little uterine anatomy review. Start off with the vaginal canal, which is the smallest, narrowest portion. And the next segment up is the cervix. And this is going to be larger than the vaginal canal in width, but smaller than the rest of the uterus. The next segment up is the isthmus, and this is also going to be getting progressively larger as we move further and further away from the vaginal canal. Next is the body, and then above that is the fundus of the uterus. You can also see in this image the uterine cavity, where the endometrial lining will be found. And also in this image are the fallopian tubes and the ovaries. Time to talk about the uterine layers. The uterus has 3 layers. The outer layer, which is known as the perimetrium, and this is also known as the serosa. It has an inner layer known as the endometrium, also called the mucosa, and this is the lining that the superficial portion of it is shed each month during menses. And then there's a middle muscle layer known as the myometrium. A cul-de-sac in the body is a space in the body where free fluid can collect, and this is especially important in the pelvis due to many structures or pathologies that can cause free fluid, such as a ruptured ovarian cyst, a ruptured ectopic pregnancy, etc. So let's talk about some of the areas where free fluid can accumulate. The first place is in the bilateral adnexa, and the adnexal areas are the space adjacent to the transverse or coronal uterus. And this is the space where you can find the ovary, fallopian tube, broad ligament, and blood vessels. You can also get free fluid in Morison's pouch, and this is the space between the right liver and the right kidney, up in the abdomen. Also, the left upper quadrant can be a space for free fluid, and this is found between the spleen and the left kidney. Back down in the pelvis, we've got the anterior cul-de-sac, and you find this above the uterus, between the uterus and the bladder, and the posterior cul-de-sac, and this is found below the uterus, between the uterus and the rectum. And this is also known as the pouch of Douglas, and this is the most common site for free fluid in the pelvis because this is a very dependent portion of the body. This is an image of the cul-de-sacs in a transvaginal uterus. The red arrows point to the posterior cul-de-sac, and you can see that below the region of the cervix is some anechoic free fluid. The yellow arrow is pointing to the anterior cul-de-sac, and this is also another potential space for free fluid to collect that would be visible on a transvaginal ultrasound. And it's really important not to mistake the bladder for fluid in the anterior cul-de-sac. The bladder fluid will be contained by the thick bladder walls. When you're first learning to scan a transabdominal ultrasound, it can be very easy to mistake the transverse cervix or the transverse vagina for the transverse uterus. In a transabdominal pelvic ultrasound, in the sagittal plane, the cervix is the region of the uterus where the uterus starts to increase in size compared to the vaginal canal, and there's also a slight to a pronounced bend in this region. In the transverse plane, the cervix is a small oval to round structure with less bulk than the transverse uterus, but thicker than the vagina. In the sagittal plane, the vagina is a long and skinny tubular structure posterior to the bladder. And in the transverse plane, the vagina is longer and flatter than the cervix, and the rectum will be found posterior to the vagina. On a transvaginal ultrasound in the sagittal plane, the cervix is the first portion of the uterus visualized on the ultrasound image. And commonly, Nabothian simple cysts can be visualized within the cervix. And when these are simple cysts, they should not be measured or documented. The cervix is the region of the uterus that will have a slight to pronounced bend on the image along the bottom wall of the uterus. And in the coronal plane, such as seen in the bottom image, the cervix is going to be an oval structure with the endometrial stripe visualized in the center. And this endometrial stripe will be smaller in thickness than it is near the body and the fundus of the uterus. And the cervix will be much smaller in caliper than the uterine body. And Nabothian cysts will commonly be visualized in the cervix myometrial layer. Now a word about the vaginal canal and a transvaginal ultrasound. Since the transvaginal probe is within the vaginal canal, the vagina is normally absent from the transvaginal ultrasound image, with the first structure viewed on the image being the cervix. However, if the transvaginal probe is pulled nearly out of the patient until the bladder can be visualized on ultrasound, you can see a hint of the vaginal canal up near the bladder. So let's talk Nabothian cysts. Nabothian cysts are benign cysts found in the cervical region in the myometrium, and they're generally less than a centimeter and generally simple. You don't want to document them when they're small and simple, which means they are anechoic with posterior enhancement and avascular. So when would you document a Nabothian cyst? When it gets large, and these can get up to 4 centimeters in size, or when there's a mural nodule or solid component or thick septations, or when there's any internal vascularity. Otherwise, it's important just to ignore them. So just to throw a kink in things, literally, the uterus likes to get very bendy, and it can be found in various positions throughout the pelvis. So first, let's talk a little bit about terminology. Ante means that the uterus is tilted forward at the cervix, while retro means the uterus is tilted backwards at the cervix. The term verted means that there is a less than 15-degree bend between the cervix and the body position of the uterus, and the uterus is fairly straight. While flexed means that there's a greater than 15-degree bend between the cervix and the body position of the uterus. Now let's combine some of these terms. Anteverted means the uterus is going to be tilted forward. It's going to face up towards the top of the ultrasound screen on a transabdominal image. And there's going to be less than 15 degrees bend between the cervix and the uterine body. Anteverted and anteflexed means the uterus is tilted forward. There's a greater than 15-degree bend between the cervix and the uterine body, and the space between the bladder and the uterus is visible. Retroverted means the uterus is going to be tilted backwards, meaning it's going to face straight towards the left side of the ultrasound monitor with a slight curve downward, and a less than 15-degree bend between the cervix and the uterine body. While retroverted and retroflexed means the uterus is going to be tilted backwards. It's going to face down towards the bottom of the ultrasound screen, and there's going to be a greater than 15-degree bend between the cervix and the body of the uterus. Now let's talk about the different uterine positions that can be visualized in a transvaginal ultrasound. The top image is of an anteverted uterus. The cervix enters the ultrasound image on the right side of the image, and the cervix is going to run right to left on the ultrasound monitor. And note, this corresponds to the ultrasound screen itself, not the position in the patient's body. The uterus body is going to run right to left on the ultrasound monitor. There's going to be a less than 15-degree bend between the cervix and the uterus body. And this is demonstrated because there's a less than 15-degree angle between the red line in the cervix and the red line that's in the uterus body. And the red arrows below the uterus are demonstrating that both the cervix and the body of the uterus are traveling the same direction on the ultrasound image. The bottom image is of a retroverted uterus, and this is where the cervix enters the ultrasound image on the left side of the image. The cervix is going to run from left to right on the ultrasound monitor, and note that this corresponds to the screen itself, not the position in the patient's body. The body of the uterus is going to run from left to right on the ultrasound monitor, and you'll note from the orange arrows below the uterus that both the cervix and the body of the uterus are running in the same direction. There's going to be a less than 15-degree bend between the cervix and the body of the uterus. And this is demonstrated by the orange line in the cervix and the orange line in the body of the uterus. There's less than a 15-degree angle between these two lines. The next transvaginal uterus position is anteverted and anteflexed, and this is in the top image. The cervix enters the ultrasound image on the right side of the image, which means anteverted, and the cervix runs from right to left on the ultrasound monitor. And note that this corresponds to the screen, not the position in the patient's body. The body of the uterus runs right to left on the ultrasound monitor, and you'll note from the blue arrows that both the cervix and the body of the uterus are running the same direction on the ultrasound screen. There's a greater than 15-degree bend between the cervix and the body of the uterus, and this is demonstrated by the blue line in the cervix and the blue line in the uterine body. There's a greater than 15-degree angle between these two lines. The next uterine position is retroverted and retroflexed, and this is demonstrated in the bottom image. The cervix enters the ultrasound image on the left side of the image, meaning it's retroverted, and the cervix runs from left to right on the ultrasound monitor. And note that this corresponds to the screen itself, not the position in the patient's body. The uterus body also runs from left to right on the ultrasound monitor. The green arrow underneath the cervix and the green arrow underneath the body of the uterus both run the same direction on the ultrasound image. There's a greater than 15-degree bend between the cervix and the body of the uterus, and this is demonstrated by the green lines. The green line in the cervix and the green line in the body of the uterus have a greater than 15-degree angle between the two lines. The last two uterine positions for a transvaginal ultrasound are anteverted and retroflexed and retroverted and anteflexed. In the top image, the uterus is anteverted and retroflexed. The cervix enters the ultrasound image on the right side of the image, which means it's anteverted, and the cervix runs from right to left on the ultrasound monitor. And note that this corresponds to the ultrasound screen, not the position in the patient's body. However, the body of the uterus runs opposite of the cervix, from left to right on the ultrasound monitor. And this is demonstrated in the arrows on the screen. You'll note that the top arrow corresponding to the cervix travels from right to left on the monitor, while the bottom pink arrow corresponding to the body of the uterus runs the opposite from left to right on the monitor. There's a greater than 15-degree bend between the cervix and the uterine body, meaning the pink line that's in the cervix and the pink line that's in the uterine body have a greater than 15-degree angle between them. The bottom image represents a retroverted anteflexed uterus. On this image, the cervix enters the ultrasound image on the left side of the image, and it runs from left to right on the ultrasound monitor. And note that this corresponds to the screen itself, not the position in the patient's body. And that's demonstrated by the top arrow. The bottom arrow demonstrates that the body of the uterus is running in the opposite direction as the cervix, from right to left on the ultrasound monitor. And there's a greater than 15-degree bend between the cervix and the body of the uterus. And this is demonstrated by the purple line in the cervix and the purple line in the uterus body. There's a greater than 15-degree angle between these two purple lines. Time to talk fibroids. Fibroids are also called leiomyomas or myomas for short, and these are most commonly benign growths in the uterus. So let's talk about all the different positions that fibroids can be found within the uterus. The first type is an intramural fibroid, and this means it's located within the myometrium. This is the middle muscle layer of the uterus. The next type of fibroid is a subserosal fibroid, and this means that the fibroid bulges towards the outside of the uterus. And remember that outer layer of the uterus is known as the serosa, or also the perimetrium. Submucosal is the next type of fibroid, and this is a fibroid that bulges towards the inner part of the uterus. And that inner layer of the uterus is known as the mucosa, or also the endometrium. You can also have a pedunculated fibroid, and this is a fibroid that projects via a stalk into another portion of the uterus. You can have a pedunculated subserosal fibroid, and this means it projects via a stalk outside of the uterus, or a pedunculated submucosal fibroid, in which it projects via a stalk into the endometrial canal. Let's explore the endometrial phases. The endometrium is going to change appearance and thickness throughout the menstrual cycle. So first we have the early menstruation phase, and this is days 1 to 4, in which the thickened lining of the endometrium is going to be shed, which is known as the superficial layer, and the bleeding is going to exit through the vaginal canal. And this is where we can see anechoic fluid within the endometrium, and this represents the menstrual blood that is being shed. The endometrium is going to appear as a hyperechoic stripe with anechoic fluid or blood within the middle of that hyperechoic stripe. Next, we have the late menstruation and early proliferative phase. In late menstruation, days 5 to 9, the superficial layer of the endometrium has been shed, and the endometrium is a thin, hyperechoic line on ultrasound about 2 to 3 millimeters thick. And then that lining is going to start proliferating. And this is the early proliferative phase. And this is when the endometrium begins proliferating or thickening between menses and ovulation. And there's 2 phases to this proliferative stage. The early phase during days 5 to 9 and the late stage during days 10 to 14. During the early proliferative stage, the endometrium appears as a thin, hyperechoic line that will continue to thicken, measuring about 4 to 8 millimeters thick. The next endometrial phase is the late proliferative phase, and this occurs during days 10 to 14, and the endometrium continues to thicken. And this is where we'll see the triple line sign on ultrasound, where the endometrium can be visualized as 3 distinct lines representing the different layers of the endometrium. The middle line is going to be hyperechoic with a subtle hypoechoic outer edge. Then there's going to be a hyperechoic tissue layer surrounding this middle zone. And note that ovulation typically occurs on day 14. Next, the endometrium is going to enter the secretory phase, and this is days 15 to 28. And the endometrium is going to continue to thicken, and now it's going to be viewed on the ultrasound as a thick hyperechoic region that may or may not have a thin hyperechoic line running down the center of it. Typically, there's going to be enhancement posterior to this thickened hyperechoic endometrium. Time to measure. Let's measure the uterus in a transabdominal image. First of all, measuring the sag transabdominal uterus. You want to measure the length, which is the longest lie of the uterus. And you know that you've gotten the image to its longest lie when you've matched the sagittal transducer to the lie of the uterus. And you know that this is the longest length when you can see the endometrial stripe elongated from the fundus all the way to the cervix. And calipers are going to be placed on the edge of the uterine tissue, and the measurement's going to be from the fundus of the uterus all the way to the back of the cervix. Next, you'll measure the height, and this is going to be 90 degrees perpendicular to the length. And this is going to be measured at the fundus and body portion of the uterus, the largest segment of the sagittal uterus. Next, it's time to measure the transverse transabdominal uterus. You want to find the largest girth of the uterus and ensure that you're not within the cervix or the vaginal canal by going all the way up anteriorly until you're out of the uterus, and then come down just a little bit, just till you're in the widest girth of the uterus. And you want to place the calipers on the edge of the uterine tissue and measure a horizontal measurement on the ultrasound image. Note that the AP or height dimension can also be measured in this view, and this would be a vertical measurement if you decide to measure it in this plane. Now let's measure the transvaginal uterus. For the sagittal transvaginal uterus measurement, you want to first measure the length from the fundus to the cervix, and you want to try to pull the probe out a bit so that the back of the cervix is measured. And you want to measure from the tissue edge to the tissue edge. And next, measure the AP, or the height dimension. And this is going to be exactly 90 degrees perpendicular to the length. And you want to measure this at the widest portion of the uterus, body, and fundus. And next, we have the coronal transvaginal uterine measurement. And for this, you want to have a horizontal measurement for the width. And you're going to measure across the widest segment of the coronal uterus. And make sure that you're superior enough that you're within the body and the fundus of the uterus rather than the cervix. Now let's measure the endometrium, and let's talk about some of the common pitfalls that happen when measuring the endometrium. First of all, you want to measure at the fundal end of the endometrium, at the widest point. Don't measure right at the tip of the endometrium, as it narrows slightly here, and it will underestimate your measurements. This measurement should be a vertical AP measurement, but you want it perpendicular to the lie of the endometrium itself, not straight up and down vertical on the image, unless this matches the lie of the endometrium. And the measurement parameters are going to change during the different phases of the endometrium and during various scenarios, such as having fluid in the endometrium. When measuring the endometrium during the early menstrual phase, you want to measure the AP dimension of the anterior and the posterior layers of the endometrium separately, because you want to exclude the fluid from the endometrial measurement. And then you want to add the thickness of the anterior layer and the posterior layer together to get the total endometrial thickness. The calipers should be placed 90 degrees perpendicular to the endometrial stripe at the thickest portion of the endometrium. This is near the fundal end of the endometrium. And also the calipers should be placed on the outer borders of this endometrial stripe from edge to edge. And a normal measurement for the endometrium is less than or equal to 14 millimeters. In the late menstrual or early proliferative phase, you want to measure the AP dimension of the entire hyperechoic endometrium at the thickest portion. The calipers should be placed 90 degrees perpendicular to the endometrial stripe at the fundal end. And a normal measurement for the endometrium is going to be greater than or equal to 14 millimeters. Note when measuring the endometrium, no matter the phase or the circumstances, you should always line up the endometrial stripe from fundus all the way down to the cervix before measuring, so that your endometrial stripe is not off axis. During the late proliferative phase, you're going to see the triple line sign on the ultrasound image. And you want to measure the AP dimension of all layers of the triple line sign and include the hyperechoic and hypoechoic tissues within this triple line sign. The calipers should be placed 90 degrees perpendicular to the endometrial stripe at its thickest portion of the endometrium near the fundal end, and the endometrial stripe should be elongated from the fundus all the way down to the cervix. And the calipers should be placed on the outer border of this endometrial stripe, measuring from edge to edge of the endometrium. And a normal measurement for the endometrium is going to be less than or equal to 14 millimeters. During the secretory phase, you want to measure the AP dimension of the entire hyperechoic endometrium at the thickest portion. The calipers should be placed 90 degrees perpendicular to the endometrial stripe at the fundal end. Do not include any posterior enhancement below the endometrium within this measurement. You should be measuring edge to edge of the endometrium. And a normal measurement for the endometrium is going to be less than or equal to 14 millimeters. Now let's talk about some different scenarios when measuring the endometrium. First, an endometrium with an IUD. You want to measure the entire thickness of the endometrium, but measure in a region that does not include the actual IUD itself. And this is demonstrated by the red calipers in the image to the left. The calipers are placed perpendicular to the endometrial stripe, and the endometrial stripe is elongated from fundus all the way to the cervix. Another thing to look for is to determine whether or not the IUD is displaced. And you want to measure from the tip of the endometrium at the fundal end to the tip of the IUD. And this is demonstrated by the yellow calipers. The measurement should be less than or equal to 5 millimeters, or the IUD is displaced. Note that a normal measurement of the endometrium in this case is going to be less than or equal to 14 millimeters. Next, let's measure an endometrium with a mass. You want to measure the entire thickness of the endometrium, including the mass within the endometrial measurement. And next, you want to measure the mass itself in 3 different dimensions: height, width, and length. In this scenario, a normal measurement of the endometrium would be less than or equal to 14 millimeters. So if the mass makes that bigger than 14 millimeters, this is demonstrating that the endometrium is thickened by that mass. You want to measure perpendicular to the endometrial stripe, and you want to ensure that your endometrial stripe is elongated from fundus to cervix. Now let's talk about the postmenopausal endometrium. When measuring a postmenopausal endometrium and the patient is not experiencing postmenopausal bleeding, and note that the patient may or may not be taking HRT, which is hormone replacement therapy, you want to measure from edge to edge of the hyperechoic endometrium, perpendicular to the lie of the endometrial stripe. This is an AP dimension, and you want to ensure that the endometrial stripe is elongated before measuring from the fundus to the cervix. A normal measurement is going to be less than or equal to 11 millimeters in a patient who is not experiencing postmenopausal bleeding. The endometrium should appear hyperechoic, homogeneous, and avascular. In a postmenopausal endometrium where the patient is experiencing bleeding, the endometrium should be less than 4 millimeters, and you want to measure edge to edge in the AP dimension with the calipers perpendicular to the endometrial stripe. And you want to look for any changes to the endometrium. Is it heterogeneous? Is it thickened? Are there any internal cystic spaces? And or is there any flow within the endometrium with color or power Doppler? Let's talk about some of the conditions that can cause a thickened, abnormal appearing endometrium. The first one is endometrial hyperplasia. This is an overgrowth of cells, meaning too many cells, but the cells are not yet cancerous. And they may or may not have atypia. Atypia means the cells are abnormal, but not yet cancerous. And this can progress or transition into endometrial cancer. And this is going to be diffuse, affecting the entire endometrium. The endometrium is going to be thickened with internal vascularity. Often it's a little bit more homogeneous than endometrial cancer, but not always. So it may be heterogeneous, and you may also visualize cystic spaces within the endometrium. Another change that can happen to the endometrium is the presence of an endometrial polyp. And these are most commonly benign, although they can be malignant. And these can be pedunculated with a stalk projecting the polyp into the endometrium and need to be differentiated from a pedunculated submucosal fibroid. They have a classic hypervascular color Doppler stalk traveling into the area of the polyp. This is a feeding vessel. The polyp is going to appear as an area within the endometrium that stands out. Contour is going to be irregular in this region. Often they're the same echogenicity as the endometrium, isoechoic, although sometimes they can be slightly more hyperechoic or hypoechoic. And you can have multiple polyps or a solitary polyp. You may have a slight amount of fluid along the edge of the polyp. The endometrium itself is going to be thickened. And sometimes there's a rim of normal endometrium around the polyp that can be slightly more hyperechoic than the polyp. Most of the time, however, it just appears like a slight contour change within the endometrium. You can also have endometrial cancer, and this can present as a distinct mass in the endometrium, and or the entire endometrium itself can be very heterogeneous and cancerous. In this case, the endometrium is going to appear thickened, and it may invade the myometrial borders. So there's going to be irregular borders of the endometrium itself. There's going to be hypervascularity present within the endometrium. You may have a small amount of fluid present within the endometrium, and it may or may not have internal cystic spaces associated with it. And this can be more focal, presenting as a cancerous mass polyp and as a cancerous polyp within the endometrium, or diffuse, where it's spread throughout the entire endometrium and the entire endometrium is thickened. The next type of endometrial change that can occur is what we call the tamoxifen endometrium. Tamoxifen is an anti-estrogen drug taken to either decrease the risk of developing breast cancer or to treat breast cancer. Tamoxifen increases the risk of endometrial proliferation, such as hyperplasia, polyps, and even endometrial cancer. An endometrium that's heterogeneous with cystic spaces throughout is a classic appearance of endometrial change due to tamoxifen. And depending on the findings, this may be diffuse thickening, where the entire endometrium is thickened, or more focal, such as a polyp. And the borders of the endometrium may or may not be irregular. Adenomyosis is another change that can happen to the endometrium, and this is where endometrial tissue grows into and invades the myometrium. This is the muscle layer of the uterus, and this can cause an enlarged uterus as the endometrial tissue continues to cycle within the myometrium, and that means it builds up, breaks down, and sheds. This occurs in premenopausal women who are still having periods and can regress after menopause. And you're going to see a heterogeneous endometrium with Venetian blind shadows. These are dark linear vertical bands that extend down across the uterus. There's going to be an irregular interface between the endometrium and the myometrium. Internal vascularity will be present, and also small cystic spaces can occur in the myometrium. Now let's talk about ultrasound image optimization for the uterus. The most important thing is to ensure that the uterus is on axis. And the sagittal uterus is on axis when the endometrial stripe is elongated throughout the uterus from the cervix to the fundus. And it's really important to be sagittal to the uterine lie and not the body. Remember all the different positions that the uterus can lie within the pelvis. The transverse or coronal uterus is on axis when the uterus is at its maximum size and the endometrial stripe is visualized within the center of the uterus as a horizontal stripe. It's very easy to mistake the transverse or coronal cervix or even the vagina transabdominally for the transverse uterus when first learning ultrasound. The transverse or coronal cervix is much smaller in caliper than the transverse uterus and rounded in shape with a tiny blip of the endometrium in the middle. The transverse or coronal vagina is flat, oval, and smaller in caliper than the transverse uterus. And the rectum is going to be visible posterior to the vagina on a transabdominal ultrasound. When optimizing the frequency, the highest frequency that allows penetration down through the cervix on a transabdominal ultrasound or down through the posterior wall of the uterus for a transvaginal ultrasound should be used. If the bottom of the uterus is darker and harder to visualize than the top of the uterus, then either the frequency is too high or the far-field TGC is too dark. The uterus tissue should be equally visible from top of the uterus to the bottom. When scanning transabdominally, if the top of the uterus is darker with shadows overlying it, slide down inferiorly on the patient to utilize the bladder as a window, and also increase the TGC to the fundal portion of the uterus. To optimize the depth of the uterus, the depth should be adjusted so that the uterus fills the screen, and you want it to be the star of the image. It's important, however, to be able to visualize the tissues below the uterus, such as the posterior cul-de-sac, to determine if there's any free fluid present. For a transabdominal ultrasound, place the bottom edge of the sagittal uterus cervix about 3/4 of the way down the screen. In the transverse plane, the bottom edge of the uterus should be located about 3/4 of the way down the image. For a transvaginal ultrasound, place the posterior edge of the sagittal uterus about 3/4 of the way down the screen, and in the coronal plane, the bottom edge of the uterus should be located about 3/4 of the way down the image. This ensures that the uterus is the star or focus of the image. When using focal zones, ideally 2 focal zones should be used for imaging the uterus to provide higher resolution throughout more of the image. The lowest focal zone should be placed at the bottom margin of the uterus for sag and transverse coronal images of the uterus. For the endometrial images, a solitary focus should be used, and it should be placed at the level where the endometrium is thickest. And this is the region where the endometrium is going to be measured at the fundal end of the endometrium. To optimize the TGC, it should be adjusted so that there's equal brightness throughout all levels of the uterus. The uterus should be a darker shade of medium gray, slightly darker than the liver echo texture, but bright enough to see the uterine tissue. so not anechoic, and slightly brighter than hypoechoic. You want to at first adjust it to a medium gray color that's similar to liver echogenicity color, and then just slightly darken it. It needs to be dark enough to visualize the hyperechoic endometrial borders, and you want to ensure that the very tippity top of your image is not too bright or too dark on transabdominal imaging above your bladder. Above and below the uterus should be darker than the uterus, but not anechoic. It's important to be able to distinguish between the different tissue types in these areas. If you cannot tell what's what, then it's too dark. If you can't tell what's what, you can also miss free fluid or a mass that lies within the pelvis. The gain should be adjusted so that the uterus is a darker shade of medium gray, and the uterus tissue texture is appreciated and the endometrial stripe is clearly visualized. If the uterus echo texture is set too brightly, it will be hard to see the hyperechoic endometrium. The gain is too high if the endometrium is not visible and structures above and below the uterus are brightly hyperechoic. The gain is too low if the uterine tissue texture cannot be appreciated and structures above and below the uterus are anechoic. The field of view or width control should be set widely for the sagittal uterus and narrowed for the transverse uterus. However, it's important that the field of view is wide enough to visualize all sides of the uterus and that there's also a rim of surrounding normal tissue on all sides of the uterus. If using field of view and the zoom control together, start off with a wider field of view because the zoom control will also narrow the field of view size, which can result in too narrow of a field of view size after the zoom control is used. The zoom control is especially helpful when evaluating the transabdominal endometrium. You just want to ensure that the image is not over-zoomed, in which one or more sides of the endometrium itself, this is the section that's being measured, the fundal or body section of the endometrium, are cut off outside the field of view. You want to zoom enough so that the area of interest, this is the fundal and the body section of the endometrium, is the star of the image. And it's okay if the bottom of the uterus in a transabdominal picture, such as the cervix, is cut out of the image, because the endometrium is the star, not the uterus. However, all visible parts of the uterus should display the elongated endometrium, and it should be elongated throughout the entire length of the image. If the endometrium looks abnormal, such as being thickened, heterogeneous, etc., then include more of the endometrium in your picture, such as the cervical portion also within the image. You also want to ensure that the image is not so zoomed up that it is blurry. The role of color Doppler when evaluating the endometrium is to look for any blood flow within the endometrium that could signal endometrial disease. And you want to evaluate the entire endometrium and have the endometrial stripe elongated from the fundus all the way to the cervix. So the color or power Doppler box needs to be large enough to completely encase the top of the endometrial stripe, the fundal and body portion, if the endometrium visually looks normal. However, if the endometrium visually looks abnormal, then the color or power Doppler box needs to completely encircle the entire endometrium, all the way from the fundal portion to the cervical portion. And this is when the endometrium looks thickened, heterogeneous, there's a visible polyp or cystic spaces. You want to optimize the color Doppler by adjusting the size of the box and the position of the box. The endometrial area of interest, this is most of the time the fundal and body portion of the endometrium, should be centered within the box, top to bottom and side to side, ensuring that there's also a rim of normal tissue around the endometrium within the color box on all sides. And next you want to decrease the color frequency and adjust the PRF lower. This should be set fairly low to evaluate the endometrium. Next, adjust your color Doppler gain. And be wary of pseudoflow. Don't want to display a color Doppler false signal, such as flash or other artifact within the endometrium, especially when the endometrium is thin and homogeneous. This would give a false impression of pathology being present when it's not.